Thank you, Dr. Kelly. The next speaker is going to speak on the benefits and adverse events of cannabinoids versus opioids. And this is, I'd like to introduce you to Dr. Jason Beaman. Until recently, he was the chair of the Department of Psychiatry and Behavioral Sciences at the Oklahoma State University Center for Health Sciences. Now he's the interim chair in the School of Forensic Sciences at the Oklahoma State University for Health Sciences. He did his Doctor of Osteopathic Medicine at the Oklahoma State University for Health Sciences, followed by internship in family medicine and psychiatry at the University of Oklahoma Health Sciences in Tulsa, followed by a residency in family medicine and psychiatry, and then a fellowship in forensic psychiatry at Case Western, Masters of Science in Pharmaceutical Sciences at the University of Florida, Gainesville, followed by a Master of Public Health at Johns Hopkins. Please welcome Dr. Beaman.
Okay, thank you so much. And can you guys hear me okay? Perfect. Thank you for giving me a little bit of your time this morning to talk about really what I think is a very important topic. Okay. And I want to start off with the last presentation. I think was perfect in highlighting kind of a lot of key points for cannabis in the field of medicine. And you'll hear different things. One of the first things you hear a lot of doctors say is, we don't know a lot about it. Well, you just saw, I think we know quite a bit about it, right? You hear people say, well, that hasn't been studied. It actually has been studied. You hear kind of two camps, like, oh, it's just all bad, or it's all good. And really, it's kind of in between. And I think that we would say pretty similar things about the benefits and risk for ibuprofen, right? Ibuprofen's good, right? It has uses. Well, what about ibuprofen like 400 milligrams, 15 times a day? What about 1,000,000 milligrams of ibuprofen, right? Okay, ibuprofen has some side effects. So what if we switch it to something maybe a little safer? What about water, right? Water can be deadly, right? There have definitely been case reports of water intoxication causing seizures, causing motor vehicle accidents, probably more deaths due to water than to cannabis, right? But I would just encourage you to realize there's really no safe substance that is taken at incredibly large amounts over periods of time. And I think the cannabinoid hyperemesis syndrome kind of helps us document that. So I'm not a cannabis expert. I have studied it, I've taught about it, I've lectured about it here in Oklahoma, but really my role is in opioids. And I spend a lot of my time fighting the opioid epidemic here in Oklahoma. I testified against the evil corporation, Johnson & Johnson, when we sued them in Oklahoma. And a lot of times there's intersect between cannabis and the opioid epidemic. And so I'm going to hope to bring a little bit of perspective to you here today. Okay, so in order to do that, you've got to know what's going on with the opioid epidemic. Okay, and it's no longer the opioid epidemic. I don't know if you've heard this. It's now the drug overdose epidemic because methamphetamine overdoses have skyrocketed. I'll sum it up. All you need to know is that more people will die today than died yesterday. Today is the absolute worst day of the opioid epidemic until tomorrow. And tomorrow will be the worst day. So out of all of the highlights that you've had to the opioid epidemic over the last decade, it's getting worse, okay? And it's getting worse, and you just saw the suicide slide, and I love that because also suicides are getting worse. And if you add in chronic alcohol disease, those three are all getting worse: overdoses, suicide, and deaths from chronic alcohol disease, in what we call deaths of despair. So what we have in the United States right now is some sort of despair problem where individuals are dying at increased rates despite all of the treatment and public health efforts. So when we talk about opioids, they have different clinical benefits. You might use them for different reasons, right? Pain, cough, diarrhea. And the reason I highlight that is because if we're going to say, okay, maybe cannabis is a safer alternative to opioids, let's first know why we use opioids. And I think everyone would agree the number one reason is for pain. Now, cough for sure. I think codeine is a very effective treatment for kind of a chronic persistent cough to help someone get over the slump, and then also for diarrhea, right? And like Imodium is a very, very low potency opioid, but in Oklahoma we've had at least 2 deaths from Imodium overdose because people were trying to get high. Do you know how many Imodium you have to take to get euphoria? 90. Okay. Yeah, we've had 2 people who have done that. Okay. At least 2 people. Okay. And so when you look at opioid use over time, something has happened in the United States, right? And from 1930 until 1996, doctors didn't use opioids. If you went to your doctor, you had to get a 3-day prescription, right? Short-term acute pain, or you had cancer. And then in the 1980s, we saw a shift towards palliative care and pain medicine. And, you know, we got to treat people differently. And so that started to open up the reins. At the same time, the pharmaceutical company said, hey, you know what? We're selling an addictive medication. We can make a lot of money here. So the floodgates open, right? And it went from like from cancer pain to just chronic pain. And if you talk to a lot of the pain doctors and anesthesiologists in the early 1990s, we didn't have chronic pain or chronic pain syndrome. We had cancer. We had multiple sclerosis. We had rheumatoid arthritis, and we would treat those pain conditions. But then in like the early 2000s and on, we started having patients with chronic pain syndrome. And I'd go into a room, I'd see a new patient, I'd say, well, I see here you're taking opioids. What is your condition? So, well, I got chronic pain condition. I got chronic pain syndrome. And I say, okay, well, where's your chronic pain at? Well, everywhere. Okay. Well, what causes it? Everything. Okay. And it's like, that's not how we do medicine, right? And then by all the guidelines at the time, based on what this individual is telling me, okay, here's all the opioids, right? Take as much as you want, as much as you need. And you can see we got in some trouble, right? We got in some trouble. Well, let's look at Oklahoma, all right? Just to show you how big the problem was. What if we had 100 people in this room right now? How many bottles would we have of opioids? And in 2011, at the height of the epidemic, if you lived in Harmon County, you would have 241 prescriptions for every 100 people in the county. 241. Okay, these are the top 10 counties. And then you see we've made a lot of progress by 2020. And what I would highlight is in the first category, if you're familiar with Oklahoma, the 2011, what's missing? Tulsa and Oklahoma County. And that's where your cancer doctors are. That's where your board certified pain management doctors are, your rheumatologists are. What on earth is going on in McLean County that they need 204 prescriptions for every 100 people? By 2020, you see that the major metropolitan counties have come back on the top 10 list. And so that represents a more appropriate right sizing of prescription to those individuals that need it. So we've made a lot of progress, and some of it's been regulation, but I think most of it has been doctors realizing that these medications have more risk than benefits, basically, than what we were told. So let's look at the opioid epidemic in real time. Here's the United States in 2003, and wherever you see dark red is an overdose rate greater than 20 per 100,000. Put that in perspective, suicide is a top 10 cause of death with the rate at 14. So anywhere you see dark red, you're probably looking at a top 10 cause of death in that county. Okay. Let's look at 2020. Okay. So when I talk about an epidemic, I'm telling you, people are dying. People are dying. This isn't just lip service. In fact, so many more people are dying that the life expectancy in the United States has gone down. I was born in 1979, and when I was born, let's say I was projected to live 80 years. If you're born today, you're projected to live less than that. Okay, even though, look at this incredible medical complex that we've constructed over the last 40 years. And in Tulsa, we have all these huge medical campuses and all these fancy machines. You're more likely to die earlier if you're born today because of the deaths of despair. Let's look at Oklahoma. Here we are. And then here we are today. And I think the most recent numbers would go ahead and fill in the other three counties. Okay, so hopefully I've encouraged you to consider that opioids might be risky. Now, we can't not use them. Absolutely, we need opioids in the practice of medicine. We've just got to be a lot more careful in what we're doing. And so in Oklahoma, especially when the medical marijuana was passed, the question is this the answer to the opioid epidemic? And so we know what's going on with the opioid epidemic. We know why people are using opioids. So let's see if maybe cannabinoids are the answer. Okay, so here's a study from JAMA looking at the use of cannabinoids and other pain treatments among adults with chronic pain in the United States with medical cannabis programs. Okay, and over on the vertical axis, you're going to see self-reported change in cannabis use. Okay, so if we can send individuals to physical therapy, they're going to use less. So physical therapy is a benefit. If you have patients that are saying, like, I want to use cannabis for my pain, okay, but also physical therapy will cause them to use less cannabis. Meditation can be helpful, and then also cognitive behavioral therapy. Okay. So there are some alternatives. This is a really, really good, very robust meta-analysis that looked at all of the different outcomes. Okay, and basically you have whether or not the individual studies, and you see them over there, whether or not they favored cannabis as improving or whether or not they favored cannabis as not improving pain. Okay, and I think you can kind of quickly see that there's an outlier up there. Buggy et al. Really, really favored improvement, but most studies showed that cannabis may improve pain, right? Most studies showed that there, in fact, no studies showed that it didn't, right? Now, this is a huge double-edged sword here. This doesn't provide you all the information that you need clinically. It provides you a lot of information, maybe as a scientist, to say there may be some benefit to pain if you're using cannabis. But to be clinical, we'd have to know, well, what were the pain conditions? What was the milligram, the concentration of THC? What was the frequency, right? Because you just can't say ibuprofen helps pain. You have to tell me how much ibuprofen for how often, and there's different types of pain conditions, right? In broad clinical science, we can separate pain into two categories, central pain and peripheral pain. If I break my arm, the pain signal's coming from down here, right? There are some individuals, and we have pain signals being generated all the time. Right now, as you sit, you're generating a pain signal. And that's why in a few seconds, you're going to shift in your chair. You're going to take pressure off of that foot, off of that leg, off of that hip, because that pain signal was going through. There are some individuals, and whenever you get a pain signal, it goes through the filter in the brain. Okay, and the brain says, here's what's going on. There are some individuals that when that signal hits the brain misinterprets it. And instead of saying, hey, this is low-level discomfort, says this is a fire. Something is going on, this is a fire, right? And so those people experience exaggerated pain, but it has nothing to do with what's going on in their body. It has everything to do with what's going on with their brain. So I think you could imagine that ibuprofen is going to affect those two categories of patients differently, right? If it's peripheral pain, ibuprofen may be a miracle drug. Tylenol may be a miracle drug. If it's central pain, then it's probably not going to help, right? And medications like we would use for depression, like SSRIs, may be more beneficial for the central pain due to the receptors that you're trying to hit compared to like ibuprofen. It's advancing here, but it's not advancing on the screen. Are we back on speed? Perfect. Thank you. All right, let's get back up to speed. Here is more from that study showing you the different populations so that if you guys have my slides, I wanted you to be able to have that. You can look at the type of pain because you can also look at like musculoskeletal pain versus neuropathic, different conditions. You can look at the formulation and how long they took it. What is not included in the study was the actual concentration of the THC. Okay, so then we have to shift gears and talk about bias in the study of cannabis for the use of medicine, right? And I have to warn you about the bias in any kind of substance that would include euphoria and addiction, right? And we saw it with the opioid companies and where they said, you know, it's fine, it's fine, it's fine. Could you think of anything more powerful as a marketing strategy than getting patients addicted to your product, right? Because then you've got a steady customer base. So be wary of any medicine that is addicting and that causes euphoria or the ability to get high. Even if it has benefits, be wary of that. And so when we look at cannabis, there's a ton of cannabis research coming out right now, but how much of that is funded by individuals who are trying to make money from it, right? Not all of it, not all of it. And there are some really, really good unbiased scientists that are just trying to figure out what is this, because you can't deny that there are some unique properties to cannabis that may help people. So we're studying that. So when we looked at bias in the cannabis studies, 14 of the 20 studies were deemed to have a moderate risk of bias. 4 studies had a high risk of bias, and only 2 studies had a low risk of bias. And there's a very kind of scientific way in the medical literature we measure bias. Does it have this points? Does it have that point? We did a study not related to cannabis, but we did a study looking at risk of bias in just the abstract. And it turns out that abstracts are incredibly full of bias. And also that's what most physicians use to make their medical decision, right? I can't read every single article that's written every single month. I mean, sometimes it's hard to read 10. And you see a really good article, you'll go to the abstract because it has everything you need. It turns out that those are just chock full of the bias of the author, right? Sometimes intentional, sometimes not intentional. We call it spin in psychiatry. Okay, so the conclusion of that big study was the findings of the systematic review and meta-analysis suggest that placebo responses contribute significantly to pain reduction in clinical trials. So placebo effect is huge when it comes to cannabis and pain trials, and that in and of itself needs to be studied more. People have expectations of what cannabis will do for them. So the unusually high media attention surrounding cannabinoid trials with positive reports irrespective of scientific results may uphold high expectations and shape placebo response in future trials. So based on what patients are hearing out in the community, they have expectations, and that expectation may contribute to a placebo effect. I testified before the Oklahoma legislature when we had our medical marijuana bill passed in the referendum, and the guy before me was just I think a therapist within the VA system. And this therapist talked about how bad suicide was and all the suicides he's seen in the VA. And he said, if we could just have marijuana, we will not have any more veteran suicide. Right? But now if you're a veteran and you're hearing about that, you're like, okay, well, marijuana is the key. And so it's a placebo effect because you've heard that there's scientific evidence, but there's not. You just saw the slide where actually there's some concern about the increase in suicide with cannabis. Okay, well, what about cannabis, pain, and opioids? And here's what I would tell you. I know that cannabis is not the magic bullet for pain because all of my pain management friends have called me for over a decade saying, hey, I've got a patient that I'm prescribing opioids to who's also using cannabis. What do I do? Right? From an addiction perspective, what do I do here? Well, if cannabis was the silver bullet, why were they still going to get the opioids, right? So people have been using both. People will continue to use both. I don't think that you can replace one with the other, okay? So we've known that for a long time, that they're not replaceable. So people who had used cannabis in the previous wave of the study, they had subsequent waves, had greater pain interference in the subsequent wave than those who had not used cannabis. Okay. In adjusted models, after controlling for age, gender, previous pain interference, pain factors, and the morphine equivalent dose, prior cannabis use was not independently associated with current pain interference. Okay, that's a big, chock-full sentence saying that some individuals who previously smoked pain or used cannabis for a pain condition may actually not benefit from future pain episodes, but that statement goes away when you adjust for things such as the opioid dose that they're using. Okay, and then what about cannabis and the strength of opioid? And when you look at strength of opioid, just like you can compare a lawnmower to a pickup truck to a tractor based on horsepower, you can compare all opioid doses within 24 hours to each other, right? Even if they're taking multiple different medications. And that's called NME, morphine milligram equivalent. And so this study actually looked at cannabis and the strength of opioids. So maybe it's not going to replace the opioid, but we can get them down on the dose. All of the bad outcomes in opioids happen as your dose goes up. And so this study failed to detect an association between cannabis use and reduced OME and a complete case analysis of the effect. So it's not going to lower the dose. It's not going to lower the dose. And that's one of the most important things. So people are probably going to want to stay on their current dose of opioid and continue to use marijuana. It's not going to reduce it. And then this study here looked at whether or not it was opioid sparing. And the results was we found no evidence of temporal relationship between cannabis use and pain severity or pain interference. No evidence that cannabis use reduced prescribed opioid use or increased rates of opioid discontinuation. The most common reasons for discontinuing cannabis use included side effects, lack of efficacy, access difficulties, and legal concerns. Nonetheless, our data and other population surveys highlight growing community interest in the use of cannabis for pain. So in this study here, they did not find, and this was a 4-year prospective cohort study, they did not find the opioid sparing effects. Okay, and then you got to think about what you're actually doing with pain and with addiction. And these two things interplay. And one of the big hooks that we got from the pharmaceutical companies and opioids was if you have pain, you can't get addicted, right? And if there's physicians in the room, we've been told that with other medications. If you have anxiety, you can't get addicted to benzos. If you have ADHD, you can't get addicted to Adderall. And that's just nonsense. It's absolute nonsense. There's no scientific evidence or mechanism to support that because the reward center in the brain is the reward center in the brain. And if it causes a dopamine surge in the pleasure center, you can get addicted, okay? You can get addicted to food. You can get addicted to sex. You can get addicted to TV and whatnot. I think Oklahoma just sued Facebook for getting addicted, right? So to say that if something magical happens when I step on my daughter's Lego at 2 a.m. in the morning and I now have legitimate pain, I can't get addicted to an opioid? No, that's just not true. So when we look at cannabis and opioids for the use of pain, we have to consider the addiction potential because there are two separate issues that may actually feed each other. Perfect. So closing thoughts, cannabis is unlikely to curb the current opioid epidemic. And we know that because we had cannabis when the opioid epidemic started, right? I mean, we've had cannabis for centuries. We've had heavy use in the United States since the 60s, 70s, and 80s. And the cannabis is only getting more potent. It's only getting more available. So it's unlikely to curb the opioid epidemic. That is not to say that cannabis doesn't have a public health role. It doesn't have a medical role. I'm saying as someone who works in the opioid epidemic, I treat patients with opioid use disorder. I don't need it, right? It just confounds it. It's not a cure for opioid addiction. As an addiction doctor, I would never want you to replace one addiction with another. I would never want you to replace one substance that causes euphoria with another. I don't say, well, you're addicted to opioids. Here's a 12-pack of beer, right? Here's some Xanax, here's some Adderall. We try not to do that. If you're addicted, one thing we try to do is get you to stop using mind-altering substances and stop this concept that if you have an uncomfortable feeling that you take a chemical to relieve it. And that's addiction 101. Is get individuals to feel okay with being uncomfortable, okay? So it's also unlikely to be a miracle drug or a cure for chronic pain. That's a very complicated picture. Pain is caused by different things. Cannabis may have a role in that for sure. And as I said, it's unlikely to be an effective treatment for opioid addiction. And remember that you can take all of the substances away. There's still going to be people out there that will go outside, stare at the sun, and spin around in circles until they feel different than they do right now. So the question isn't, why is there so much of this substance available? The question is, why do people want to feel different than they do right now? All right, and there's my email address. Feel free to reach out with questions. Thank you very much.